Well, thank you very much, Corey, for inviting me. It's really nice to be in New York. I have not been able to make the slides go forward. What do I have to point at? Point at that screen? There we go. I have no disclosures. So this is a topic that was given to me by Corey. Thank you, Corey. And I thought I would break it down into the categories of patients that we see, because I think the answer to the question in the end, to give you a little hint, is probably going to be no. In the neoadjuvant setting, we really don't know what to do even in mutated patients, let alone in patients who are wild type. In the adjuvant setting, in the early and intermediate stages, it seems that there's no clear clinical trials evidence of benefit, and there are some trials that seem to show worsening outcomes, in fact, even in patients with mutated receptors. In the metastatic first and second line setting, probably less effective than chemotherapy for unselected patients, but probably better than nothing, and biomarkers will help to show the way, and we'll talk about some of those. And in the third line, so this original approval that Corey alluded to, it is certainly better than nothing across all comers, but there are probably subsets that we could do better to adjust. So skipping over neoadjuvant, for which there are no data at all, looking at adjuvant in unselected populations. This is the BR19 trial. This was a trial in patients who were resected and then were randomized to gefitinib versus placebo. This was the days before erlotinib in the United States. And the trial was amended when adjuvant chemotherapy came into play to allow adjuvant chemotherapy for those who were appropriate. The disease-free and overall survivals are shown here, and thank you to the organizers for putting this on everybody's iPads, because I was really afraid that these were not going to project to the back once I saw the rooms. You can see that you would normally think on a trial that we were presenting that the blue line would be the experimental line, but indeed in this trial the blue line is placebo. So there seems to be certainly no advantage to the experimental intervention, and there is a strong suggestion that there may be some detriment here. So this was probably not the way to go. This was broken down subsequently, and I apologize for the colors in this slide. It came from Dr. Perez-Soler's presentation last year at ASCO. The trial was looked at for patients who were wild type versus mutated, and again in this graph, the red line is the placebo in both of these graphs. So again, even in a mutated patient population, we're not seeing any hint of a survival advantage with adjuvant gefitinib. What about in patients who have later stage? This is the SWOG 0023 trial presented by Karen Kelly a few years ago. This trial was designed after the SWOG backbone for stage 3 patients, chemotherapy with etoposide platinum, radiation, then consolidation docetaxel, and then a randomization to gefitinib versus placebo. And once again, the blue line here is gefitinib, the yellow line is placebo, and one can see that there is certainly not a hint of an outcome advantage in overall survival. So we don't see any benefit there. The Dartmouth group did a similar study at about the same time with their backbone at the time, which was carboplatin docetaxel, I believe, and randomized the patients at the beginning rather than at completion of primary therapy, and did not have a consolidation arm. But yet again, you see that the erlotinib, which was used in this case over gefitinib in the sort of tan color, did not show a survival advantage over the placebo. So we probably don't have a role unselected in the adjuvant setting. So moving on to metastatic disease, and we'll spend the rest of the discussion on that. There's clearly a subset of non-mutated patients for whom these drugs are effective. Multiple pathway blockade looks encouraging, and we'll talk about a little bit of that as we go on today. But we definitely need strategies along with biomarkers to help show us. And then we get back to my answer to can we do this in unselected patients? And the answer again is no, we just have to figure out how to select them properly. So looking at maintenance in stage 4 disease, the Saturn trial should be familiar to many of you. This was a trial with a progression-free survival primary endpoint, and this shows the overall primary progression-free survival in the intent-to-treat population with a hazard ratio of 0.71. So just to remind you, this was upfront primary platinum doublet chemotherapy followed by a randomization to erlotinib versus placebo. The overall survival had a still positive hazard ratio, although not quite as much, with a hazard ratio of 0.81. And the median overall survival difference was a month. So this is statistically significant. Is it clinically significant? That's a little bit harder to tell. And there's probably a population that one could select out of this where we would get better numbers. When this was broken down by mutation, not by mutation, excuse me, by IHC and FISH status for EGFR and by mutation status for KRAS, not unsurprisingly, on the left side, we see that the benefit is mostly in those patients that are IHC positive and or FISH positive, and that the RAS mutated population did not benefit, although the RAS wild type population did. The investigators were to really be commended, however, for getting the biomarkers done. So this is a good paradigm for how we can do this. They were able to get biomarker analysis on the majority of patients that went on to trial. They looked at prognostic effect by looking at biomarker status and what happened in the placebo group, and did not see an improvement in any subgroup, but did see that RAS mutations were a negative prognostic factor. And looking at just what they were able to do, in the evaluable patients, they were able to get biomarkers in the vast majority of patients on the study. And the study population was really validated in that you saw what you would expect to see. Most patients were EGFR IHC positive, about half were FISH positive, about 20% had RAS mutations, and about 11% had EGF receptor mutations. So what about moving on from maintenance to the second line? This was Luis Paz-Ares' discussion at ASCO this year, looking at 4 of the several randomized trials that have been done comparing EGF receptor TKIs versus chemotherapy. And highlighted here are the hazard ratios for progression-free survival, and we can see that none of these show a hint that the targeted therapy would be better than chemotherapy. I'll take a little bit more time to talk just about 2 that were presented this year at ASCO, looking at second and third line treatment after platinum doublets, the Taylor study, which is an Italian study of a couple of hundred patients randomized to erlotinib versus docetaxel at the usual Western dose, and the Delta study, which was done in Japan, about 300 patients randomized to erlotinib, with the comparator arm being the Japanese dosing of docetaxel, which is a little bit lower than ours. And this study did include some patients who had EGF receptor mutations. So the Taylor study, to begin with, on the left, you can see the overall up here and the progression-free survivals, with the docetaxel being in blue and erlotinib in the salmon color. The progression-free survival favored docetaxel, as did the progression-free survival at 6 months, as did the overall survival after progression. But there were some patients who did respond in this wild-type population to targeted agent. There were 3 patients who responded to erlotinib, and the investigators actually went back and looked at their samples to be sure that they truly were EGF receptor wild-type, which indeed they were. So the implication of this study is that it's probably not the best idea to treat patients with reasonable performance status and who are eligible for chemotherapy, second line, who are wild type with EGF receptor TKIs in the form of erlotinib anyway, over chemotherapy in the form of docetaxel. We are increasingly doing other molecular prognostic, predictive, and subtyping procedures, and so some of these patients should be tested at least for other markers. And there are a number of other mutations which warrant testing now for trials and may warrant testing very soon in the non-trials population. We need to discover better biomarkers. But again, what happened to those 3% that responded to erlotinib? How do we predefine that group? If we can predefine that group, we can maybe answer Corey's question. The Delta study, similar design, patients who had been treated with 1 to 2 prior regimens, at least one of which was a platinum regimen, reasonable performance status, reasonable stratifications. Primary endpoint was PFS again, randomized to erlotinib versus docetaxel. These did have some mutation-positive patients, and there was a little numeric imbalance in the wild-type patients between the erlotinib and the docetaxel arms, although that was not statistically significantly different. And again, the progression-free survival, erlotinib in blue and docetaxel in the pink color here, this was not statistically significantly different, nor was the overall survival in the unselected patient population. Looking at the population of wild-type patients, we do see that, again, here's the erlotinib in blue and the docetaxel in pink. There is a survival advantage to docetaxel, which is statistically significant with a p-value of 0.01. The overall survival, however, is not different. So what about combining the agents with chemotherapy in unselected patients? Maybe we can get things better that way, or combining with other targeted agents. The beta lung is quite elderly now. It must have been designed at least 10 years ago. I think this looked at erlotinib versus pemetrexed versus bevacizumab versus placebo, and enrolled a lot of patients, 600 plus patients. Median progression-free survival was better for the combination than for erlotinib alone, with a highly statistically significant hazard ratio. However, once again, we see no advantage in overall survival. Atlas was sort of the reverse of the beta lung. Everybody got bevacizumab, and the randomization was to placebo versus erlotinib. And again, we see that progression-free survival advantage. Is this clinically significant? I think that still remains to be seen. Talking about the Arcule product, which is now called Tivantinib, this has been another one of our somewhat sad tales. The randomized phase 2 data were presented a couple of years ago, looking at erlotinib with or without the MET inhibitor, and there was no difference in hazard ratios initially in the two patient populations. These were statistically not significant for either PFS or overall survival, but it was felt that there was some prognostic factor imbalances that could be accounted for statistically, and after that statistical evaluation, it was felt that there was a borderline significant difference in PFS and overall survival, which was enough to go on to a randomized trial, the so-called Marquis trial, which unfortunately was stopped early because it did not seem to be meeting its endpoints. And so sadly, phase 2 promise, which has probably not shown an advantage in phase 3. There are, however, ongoing evaluations looking at MET high and low expressors to see if we can find a group that does work. Onatuzumab, which was presented at ASCO in 2011 and published, I think, last week in JCO Online last month. This was a similar study with another type of MET inhibition with a monoclonal antibody. Overall, again, there was not a statistically significant improvement in addition of onatuzumab to erlotinib alone with a non-significant hazard ratio, but looking at high MET expressing tumors, there was a doubling of progression-free survival compared to erlotinib alone with a hazard ratio of 0.53, with a median progression-free survival of almost 3 months in the doublet. And in high MET expressing tumors for overall survival, so now we've got a survival advantage, we have a tripling of overall survival with a hazard ratio of 0.37 with manageable adverse events. So perhaps this will be the way forward in this MET overexpressing population, and this just shows the progression-free and overall survival graphically. On a different tack, looking at biochemical ways to approach EGFR TKI resistance, Karen Reckamp presented this a year or two ago at ASCO, looking at erlotinib with or without high-dose celecoxib with the hypothesis that if you simultaneously target COX-2, you can overcome prostaglandin-dependent resistance and improve anti-tumor response. This was a randomized 1-to-1 trial, placebo versus celecoxib, with a primary endpoint, again, of progression-free survival and with multiple correlates. And the results of this in the EGF receptor wild-type population showed a PFS for the combination of 3.2 versus 1.8 months for erlotinib alone, with a significant improvement in 6 and 12-month survival in the combination group. And this may be because of this subset of patients who have elevated baseline PGE. In that subset of patients, the response to erlotinib alone the progression-free survival to erlotinib alone is only 2.2 months, but that can be improved to 5.6 months with the combination. So what else can we look for in the last few minutes? I'm going to talk about some proteomics. David Carbone presented this slide at ASCO in 2013, looking for other ways to evaluate these non-mutated patients to see if we can find a way to optimize these drugs. And Vanessa Gregorich presented at both ASCO and ISLAC the results of the PROSE study looking at Veristrat stratification, so I'll spend the last few minutes talking about that. So in second-line non-small cell, obviously, erlotinib and single-agent chemotherapy are both relatively common. We've heard from the Taylor study that it's probably not a great idea to use EGF receptor-targeted therapy in a patient population that's completely unselected. Veristrat was developed over a series of years and is a mass spec test which looks at patients based on 8 peaks from the mass spec that are thought to be peaks containing pro-inflammatory proteins that may be associated with host response. And the strata are simple into good, which tends to be about 60 to 70% of the patients, or poor. Retrospective studies that I'll spend a couple of minutes on have shown that Veristrat poor patients have worse outcomes than Veristrat good patients, and also that the poor population does not seem to benefit from the EGFR TKIs. The PROS study, which was presented at ASCO and ISLAC, is a prospective phase 3 study evaluating whether Veristrat stratification can predict outcomes. So to show you a little bit of the retrospective data, ECOG 3503 was a single-arm, first-line platinum ineligible population. These were erlotinib-treated patients, and when they went back and looked at Veristrat, the Veristrat good classified in green here and the Veristrat poor in the gray, 10.1 months versus 3.5 months with the erlotinib. And again, we saw that this is a statistically significant outcome with a 1-year survival advantage and a median survival advantage. In squamous histology, a subset analysis for a couple of trials showing, again, a very significant predictive value in this retrospective analysis with a median survival of 15 compared to about 3 months. The BR21 study, which was the trial which resulted in approval of erlotinib in the first place, was also queried by Veristat stratification. Veristrat good, again, in about 60% of these patients, and we could determine, or they could determine Veristrat in the vast majority of patients that were looked at. They had 441 of the original trial cohort of 731 available, and they were able to classify the vast majority of them. This is the original BR21 overall survival showing the erlotinib benefit of approximately 2 months, broken down into Veristrat groups that showed that the statistically significant survival benefit was confined in this retrospective analysis to the Veristrat good patient population treated with erlotinib with 10.5 months compared to the Veristrat poor population treated with erlotinib with a median survival of only about 4 months. So that led to thoughts that a prospective trial would be helpful. And the PROS trial, which was presented for its primary endpoint of overall survival at ASCO and for secondary endpoints at ISLAC, was such a trial. Patients were prospectively Veristrat tested. The Veristrat testing was blinded to both patients and investigators. This is, once again, a second-line trial. The Veristrat good patients and poor patients were randomized 1-to-1 to chemotherapy with either pemetrexed or docetaxel versus erlotinib. There were 285 patients that were randomized and no major flow issues. The disease control and objective response rates were shown here in these graphs, and there were no complete responses. There was also no significant difference in response rates between the various arms. And in the overall patient population, there was no statistically significant treatment effect in either PFS or OS. But in the Veristrat good population, again, we saw no statistically significant difference between chemotherapy and erlotinib for overall survival. However, in the Veristrat poor population, we see that there is a statistically significant benefit of chemotherapy over erlotinib in overall survival and a trend in progression-free survival with chemotherapy shown in the blue and erlotinib shown in the green here. In the patients whose Veristrat status, in the patients whose EGF receptor status was either wild type or unknown, the trends were similar, but the subgroup was smaller. So the authors concluded that Veristrat was predictive for overall survival outcome. There were some interaction issues which were probably based on a very short PFS. Veristrat poor patients on erlotinib consistently seemed to do worse, especially in the Veristrat poor and erlotinib, especially in overall survival. So we have to think about whether we should use this as a stratification for patients who are unmutated and for whom we want to consider using this agent. So I'm concluding with the obligatory but very simplified target cartoon. And in answer to Corey's initial question, can we select these unselected patients? The answer is probably we can make increasingly small subsets that we do select, and possibly with multiple target inhibition, we can do something in the truly unselected patient population. But I think overall the answer to can we select an unselected group without finding something else with which to select them is no.